We promised you answers to your questions this afternoon about COVID-19 vaccines in the Black community. We have an expert panel with representation from right across the country. Welcome and thank you all for joining us this afternoon for this special opportunity to hear from Black members of Canada's medical community. These medical professionals have been kind enough to lend us their time and expertise on COVID-19 vaccines. We really appreciate your willingness to donate your time this afternoon, and we know that it comes from love of your community, so we appreciate you. These are questions from community members. They've asked us to pose to you, and we appreciate you being here to answer them. This is a judgment-free zone. There are no bad questions. Dr. Burt, are you there?
Yes, I'm here.
Right there. And you have the pleasure of getting the first question this afternoon. So it says, can you explain the different types of COVID-19 vaccines?
Thank you, Dwight. It's a real pleasure for me to be part of this panel today. As you said, I'm an immunologist, and for the last 30 years, I've been working in the Canadian vaccine industry to develop improved vaccines against viruses such as flu and emerging viruses like SARS. I'm also a member of the Toronto Black Task Force on Vaccine Equity. And during my time in the vaccine industry, there have been great advances in the technology. And the recent authorized mRNA and DNA vaccines are just perfect examples of the scientific innovation that have taken place. Traditional vaccines are often inactivated whole virus or purified proteins from the virus that the vaccine is intended to protect against. But in the case of the new mRNA and DNA vaccines, these vaccines are in fact the recipe or the genetic code that tells our cells how to make the protein. In this case, it's a spike protein that's on the surface of the SARS-CoV-2 virus that the virus uses to enter and infect our cells. Now, our cells have the machinery that normally converts a gene or recipe from our own DNA into RNA, then into protein. So when we're vaccinated with these new vaccines, our cells make the S protein, and our immune system recognizes this protein as being foreign and makes antibodies and T cells that can defend us from the virus when it tries to infect us. So we have 4 vaccines that have been authorized in Canada. The Moderna and Pfizer vaccines, they have the code or the message for the S protein in the form of the mRNA. And this is wrapped up in a lipid or fat material that protects it from breaking down. For the AstraZeneca and the Johnson & Johnson vaccines, the recipe or the code is in the form of DNA. And this is delivered by a non-infectious transport virus called adenovirus. And once our cells translate the mRNA codes into protein, the codes are degraded. It's a bit like the message that Nathan Hunt in Mission Impossible receives that self-destructs within a few seconds after he reads it. The vaccines have different storage temperatures. The mRNA vaccines are temperature sensitive, so they have to be sort of lower temperatures than the DNA vaccines. But these new vaccines that have been authorized are all genetic vaccines.
How were they developed so quickly? That's one thing you hear from people.
That's an important question that many people have, not just in our community, but in most communities. Mm-hmm. And there are really 3 main factors that have contributed to the rapid development of these vaccines. I think what a lot of people don't understand is that the technology behind the RNA and the DNA vaccines has actually been in development for 15 to 20 years. There are many scientific publications describing the technology, how it evolved and had been refined over that period of time to where it has now been successfully used for COVID-19. And these prototype vaccines were tested in animals in the situation of SARS and MERS as vaccines. And so that knowledge from all of that research has been applied to COVID-19 vaccines. Also, the clinical trials that were done were performed in a way that would enable us to quickly indicate whether the vaccines were safe and effective. And what happened was that certain phases of the human clinical trials were allowed to proceed in parallel without compromising any safety or cutting corners. There's also an excellent response from the public in terms of being recruited to participate in the trials. And the trials themselves took place while the virus was widely circulating, and this enabled the efficacy of the vaccines to be clearly demonstrated. And finally, all of this was underpinned by the unprecedented level of cooperation between researchers, industry, and regulatory authorities that also benefited from a massive investment by the governments in the world.
I'd like to go next to Dr. Zainab Abdurrahman. How close was I, Doc?
That's pretty good. It's Zainab Abdurrahman. Yes.
Abdurrahman. I don't know if it's the hard C or the soft H. Okay. A question now. Can you summarize what we know about the safety of these vaccines?
I'm Zainab Abdurrahman. I'm an allergist and clinical immunologist. So I see both adult and pediatric patients. I work mainly in the community in the Greater Toronto area, as well as working at McMaster University. I'm also on the Black Scientist Task Force for Vaccine Equity with Dr. Burt. And so in my role at McMaster, I also focus on being the vaccine lead for the allergy lead, rather, for the special immunization clinic, seeing adverse reactions to vaccines. So in terms of the safety, this gets rigorously studied. As Dr. Burt was talking about, all of these vaccines still went through the same levels of study as any other vaccine and any other medication. And so with that, they start off initially actually looking at safety studies and then looking at dosing studies. And after that is established, they do a bigger study to see how effective it is when you get into a large population. And all the time, safety is always being addressed. And if there are any abnormal safety signals or you're seeing too much of adverse events, studies actually get shut down. And that is a part of any of the studies we have now. If we're seeing increased danger to patients, the study actually gets closed. So that's constantly being addressed. And that was the same for all of these new vaccines. With that, with any vaccine, you activate your immune system. So you're going to expect to see certain things, sore arms, sometimes some swelling. Maybe you can even feel your lymph nodes because we're tricking your body into thinking you have a bit of infection. But the important things in terms of safety is you will not get the COVID-19 virus from any of these vaccines. None of them are live, so they cannot infect you. In addition, it's very rare to have any of the kind of serious adverse events. With regular vaccines, we still see, the rare anaphylaxis happen, about 1 in a million. Currently, with the mRNA vaccines, we're seeing it about 2 to 5 per million doses. And with the other newer ones, probably somewhere in that kind of 1 in a million. But we did not see any kind of increased rate of serious adverse events, such as anaphylaxis, to the point that we would not consider them safe, or other concerns about other issues from a safety standpoint. So safety was established. And even since then, we're constantly following up with any vaccines that are in kind of production and in use in our country. So even the ones that you may not even think about, like your MMR or other vaccines, anytime there's any issues around it, we still collect that information. They still get investigated. And that is the same with any of the new vaccines. So there is a big focus on safety in any new vaccines, as well as the vaccines we already have. And any of those are always reported and fully investigated. So if for any reason there's a delay and we start to see that when it's in use, we're able to get information about it. So now we know that these have been used and over 100 million doses have been given, especially with the first 2 that were available. So we've been able to see that they are very safe and people are tolerating them well.
We heard a lot of talk in the news this week about AstraZeneca and blood clots, but it seems that the information that's now come out is that the blood clots are no different than what you have in the general unvaccinated population.
Exactly. And that's what happens, when you notice, we had a couple of people with blood clots, they get reported and then they get investigated and they look, okay, how many blood clots did we see? What do we see generally in the population, even if they did not get this vaccine? was it a higher frequency? And they did not see that. But we're always collecting that data because we always want to make sure that you're not going to see a later safety signal. So the fact that this is coming out should reassure people that anytime there's a signal, it's going to be investigated. It's not going to be kind of brushed under the carpet. It's still going to be looked at, and we're going to make sure that it's safe. So those were looked at, and they did not see an increased signal or causality with it. So for that reason, in Canada, we are still providing the AstraZeneca vaccine at this time.
All right, thank you, Dr. Abdurrahman. Let's head out to the West Coast now to Dr. Tex Kassoon. He's a member of the BNI Health Committee, Vancouver. The question to you, Dr. Kassoon, are the COVID-19 vaccines that are being considered for Africa and other developing regions of the world the same as the ones being used here in North America?
Yes, in short, the vaccines that are being used in those countries are the same being used here. But bear in mind, there are different sort of strains that are now popping up in different parts of the world. And in fact, this is really a moving target. And over the next period of time, we will hear more as to what happens in various parts of the world and whether there are different sort of, I would say, tweaks in the vaccine to accommodate various strains.
Why should Black and other racialized people be given priority for vaccination?
Well, I think the data is very clear. If you look across the board, both in the United States here and in Britain, we find that the Black and racialized communities are sort of disproportionately represented in those who are affected. Also the First Nations communities. And not only are they disproportionately affected, they are also disproportionately suffer from severe disease, and the outcome is very poor. So for instance, across Canada, one can look at the infectivity rate based on the sort of proportion of the population. It's about 3 to 10 times higher, and so is the mortality rate. So this is a vulnerable group, and the fact is that most national societies or ethical societies, ethics will tell you that those vulnerable groups need to be prioritized.
And it seems like it's not so much anecdotally from the color, from kind of jobs that these folks are doing.
Absolutely. I think that there's no doubt minority and racialized group disproportionately represented in the poor socioeconomic class. And while many of us can work from home or indoors, they are the ones in the service industry, in the food industry, who serves us, bring food to the table, etc., who are in the grocery stores, transport, those things. So they don't have the option. They, because of poverty, lived in sort of multi-generational homes and don't have the same ability to protect themselves as far as physical distancing, etc. So the fact is that, in fact, most infectious disease has a big socioeconomic overlay. In fact, poverty and inequity is one of the major issues that lead to that. So it's not the pigment in the skin, it's what the pigment in the skin has really relegated us in society.
Let's head to the Maritimes next, out to Halifax for Dr. David Haas, infectious diseases specialist. Dr. Haas, is there a best vaccine against COVID-19?
So I'm Dr. David Hawes, and I'm here in Dartmouth, Nova Scotia, sunny Dartmouth, Nova Scotia. I'm a retired infectious diseases and internal medicine specialist, and I also belong to the Health Association of African Canadians. So the short answer to your question is yes, there is one best vaccine, and that's the one that's available to you. So let's dig into that a little bit. Longer answer. You know, it's confusing because there are a lot of numbers being thrown around. Moderna, Pfizer, they're over 90% effective. Johnson & Johnson is 60 to 72%. And I think it does get very confusing. But we need to recognize that the endpoints of these trials are different, and that these trials were done at different times in different locations. For instance, Pfizer and Moderna were done before the variants came up. Johnson & Johnson was done actually while a variant was running around in South Africa. The one number that I need everybody to remember is 100%. So all of these vaccines are 100% effective in preventing severe illness and hospitalization. All of these vaccines are 100% effective at preventing death. And if you remember that number, then the best vaccine is the one that comes to you.
What is your advice, Dr. House, for pregnant and breastfeeding individuals who want to get the COVID-19 vaccine?
Short answer. Consensus statement from the SOGC, Society of Obstetricians and Gynecologists of Canada. Women who are pregnant or breastfeeding should be offered the vaccine if they're eligible and there are no contraindications. So let's talk a little bit. Remember again that it's a balance between the potential risks and benefits. Women who are pregnant, although it's not a huge number, but there is an increased risk of adverse outcomes with COVID infection. About 11% of these women may end up in hospital, 4% of them in ICU. There may be preterm delivery as well. So if there's a woman who is pregnant, who is in a situation of high risk, the vaccines, which we know, you heard about them before, they're not live vaccines. They do not change the DNA. They do not reproduce or replicate in cells. These vaccines are safe to give. And although in the clinical trials, there was no deliberate inclusion of women who are pregnant and breastfeeding, there are women who reported pregnancy during the trials who had active vaccine with no problems. There is a registry in the US, over 40,000 women have registered who've either had the vaccine deliberately as a choice or inadvertently, and again, no red flags. So these vaccines are considered to be safe for women who are pregnant and breastfeeding.
Thank you for that, Dr. House.
Yeah.
Let's head back to the left coast, as we like to call it, and Dr. Gina Ogilvie. She's works in women's health in Vancouver. Dr. Ogilvie, why not just get everyone infected and become immune rather than taking the vaccine?
Yeah, I think we've heard some of this talk, and I think the reason it's just not the appropriate approach is, frankly, this is a very serious disease.
This is the herd immunity talk, basically.
This is the herd immunity conversation. And unfortunately, what we know and have learned from this condition over the past year is that while a percentage of folks won't get hospitalized, we do know, and particularly as you get older, there's an increased chance of needing to be hospitalized, needing to be ventilated, needing to have ICU care, and an increasing risk of death. And the other thing that we're learning is there's a condition called long COVID. So even people who have mild to moderate infection, we know can have long-term and ongoing symptoms
that they long haulers, we're calling them,
they're
right?
they're called long haulers now. So while that was initially floated, and we saw that in some countries like Sweden, where they thought, well, let's try this approach, we now have more than enough information to show that that's not the strategy, because we're going to leave people, some with very chronic long-term outcomes, but other people will have very severe consequences and even pass away. So that's why we're so thrilled to have the vaccine to actually prevent the infection, because that's really the way we want to go.
And another question, do we know yet if Black people should expect the same results as the broader population?
So the clinical trials were actually very good at recruiting a diverse participants. And if you take a look at the data within the clinical trials, you can actually see they've looked at diverse participants around a whole variety of cultural and racial backgrounds, with chronic diseases, different age groups. And so there's lots of data there. And what we see is that, particularly for this conversation, Black folks do very well with this vaccine. They've had great outcomes, great protection. So yeah, we can absolutely expect folks to actually benefit from that. And I think that's why this whole panel is here, is we're so excited about the opportunities this vaccine presents to the community that has shouldered a greater burden of disease, to actually have an intervention that will actually prevent them from both getting the disease, but more importantly, prevent them from having those very serious outcomes that we know this community has shouldered to a greater degree than lots of other communities.
Let's head to our nation's capital next for Dr. Hughes Loemba. He is a virologist in the Ottawa Hull region. And Dr. Loemba, let's start with, it's a fair question. We said there are no bad questions here. This question says, can I get COVID from the vaccine?
My name is Hugh Loemba. I'm a virologist and a clinician, family physician. So I'm a hybrid physician, both a lab person, a PhD in virologist, but also a family physician. So let's go to the question. The vaccine is not made of the virus. It's just a part of a virus, a small fragment of a virus. Actually, most of the vaccine, what has been approved, the 4 vaccines we have approved, and those who are in development, are all targeting the same piece of the virus, the S protein. So the spike protein, and it is not even using all the spike protein gene or protein, actually. It's using half of the S protein. The subunit number 1 of S protein, but the one that attached to the receptor. So there is no way that small piece of a virus could trigger the disease of COVID-19. The only issue that it does is to give the instruction to your body to recognize that piece of a virus. And once you get exposed to the COVID-19 disease, so you have already antibody made up to fight against that piece of COVID-19 virus. So there is no way at any point you can get a disease from getting this protein. So the vaccine are not meant for making someone sick, as compared to other intervention. We may have some medication, but the vaccine is for giving vaccine to healthy people to help them to stay healthy. So let me translate everything in French. Pour ceux qui sont là en français, le vaccin, la question c'était pour savoir, est-ce que en prenant le vaccin contre la COVID-19, est-ce que je peux tomber malade, avoir la COVID-19? La COVID-19, c'est suite à une exposition au virus entier, le virus SARS-CoV-2 de la COVID-19. Mais le vaccin n'est pas fait de tout le virus entier. C'est juste une petite portion de la protéine S, la protéine de surface du virus qu'on appelle spicule. Et c'est même pas toute la protéine S qu'on prend pour tous les vaccins qui sont en développement ou ceux qui ont été approuvés. C'est juste la moitié de cette protéine-là. Et donc, en vous vaccinant, vous avez le vaccin donne l'information à votre système immunitaire de fabriquer des anticorps contre cette moitié de la protéine S. Et quand vous allez être exposé à ce virus-là, si vous êtes malade, ou bien avant que vous tombiez malade, vous avez déjà des anticorps contre cette petite portion de la protéine S. Donc, il n'y a aucun moment où on peut penser que ce bout de protéine peut vous donner la maladie. Les vaccins, c'est fait pour garder les gens en santé. Ce n'est pas pour les rendre malades.
All right. Thank you, Dr. Loemba. And since we're at Ottawa Hull, let's make a short drive down to Montreal and talk to Mrs. Maud Pierre next. I should introduce yourself and also answer this. And I find this one really interesting. Somebody's asking, they're curious as to whether the Pope and the Queen have been vaccinated. And I'm not sure where you got that question.
I'm glad to be here this afternoon. I'm a nurse from Montreal, and I represent the Haitian Nurses Association. And the first funny question is, both were vaccinated, the Pope in January and the Queen in February, because the Pope is in his 85th years, and the queen is 94 years old. So yes, they've been vaccinated.
Okay. The next question for you is, and this is a good one too, if I am getting other vaccines, do I need to space them out from the COVID-19 vaccine?
Yes, you do. Although there's no counterindication, you have to stop, you have to give an interval of 14 days before you get the COVID-19. And once you get the COVID-19, you have to wait 28 days before you resume the vaccine that you were taking before. That's the answer to that particular worry about
And you know what, your answers are so clear and concise. I'm gonna give you a third one because you're going through them so quickly. And this is a good one too. Do I still need to wear masks after getting the vaccine?
Until we can say the pandemic is more or less over. Yes, after the vaccine, because you know, even though you have the vaccine, you still can get infected. And then you don't want either to give it to people that are not yet vaccinated. And until we reach what we call, and it's on quotation, herd immunity, immunity, like 75 to 80%, and that varies of the area you live in. Montreal is different from the out region because they have less people. So until you have enough people receive the vaccine, yes, we have to keep doing the sanitary measures, washing our hands, wear masks, keep social distancing. We still need to do that.
Let's head to Alberta next.
I am Bukola Salami. I'm an associate professor at the Faculty of Nursing, University of Alberta, and my research area is mainly on the health of Black people.
First question to you is, if I had COVID, is it safe for me to get vaccinated?
So if you have COVID, it's better if it's recommended highly that you wait until you don't have COVID-19 anymore for you to get vaccinated. Vaccine will not cure you from the COVID infection you have. And getting a vaccine when you have COVID is just increasing the risk of you spreading that COVID-19 to others.
I think they want to know too, if they've had it in the past, is it safe to get it in the future also, the vaccine?
If you've had COVID in the past and your COVID, once your COVID infection is resolved, yes, please do still get the vaccine. And you know, it's highly recommended that those who already have COVID-19 still get the vaccine, because if you had COVID in the past, you can still get COVID again.
Can one get the first dose with one vaccine and the second with another vaccine? I'm just saying not, and I know I'm not an MD, but.
You should be getting the same dose, the same type of vaccine.
Are Black elderly people a priority for the vaccination?
Generally, elderly people are a priority for the vaccine. So, you know, if you're a Black person that is 30 years old versus a Black person that is 85 years old, the 85-year-old will get a priority. But the fact that you're Black, I think in most provinces, and I think that's where the inequity currently stands, is that we have the highest rate of COVID-19 infection. But being Black, at least in the provinces that I'm aware of, does not give you a higher priority than not being Black. So a Black elderly does not have a higher priority than a white elderly, but a Black elderly has a higher priority than a young Black person.
Thank you, Doctor. Let's head to Montreal again, and Ms. Thierry Lindor. Hopefully I've got that one. She's a community leader in Montreal, and actually Mr. Thierry Lindor. Let me see if I see him on my screen here. Maybe coming up shortly. Hopefully he is with us. Can you comment on the major reasons for vaccine hesitancy in your region, Mr. Lindor?
Well, according to our data at Colors of COVID, which is a platform that collects race-based data, the quick survey, we're about to launch our second survey, but it has to do with miseducation. So when we surveyed the people that participated in the Colors of COVID survey, our first set of questions did not include vaccination, but it was clear as day once we did a preliminary survey for the second round of questions that it had to do with education. It had to do with trust and education based on the way Quebec. And when you have a premier that doesn't recognize systemic racism, it's very hard also to even work on this trust relationship, because let's remind everybody on the call that our premier actually promised to collect race-based data and then backtracked on that promise based on the fact that he said, according to his government, that this was sensitive data. And then we ask, who did he survey in regards to who does that? Because the question we have to ask ourselves is, it sensitive to who, right? And yeah, so to us, so far, the data shows that it has to do with trust and lack of education.
And how are you trying to battle that in the region?
So we don't necessarily look to battle this. What instead we look to do, and we believe that collecting this data is crucial in order to combat. You can't fight what you don't measure, right? How do we know that old people are dying more than young people? We know this because we collected the data, and we believe that information can be converted into data, and data is converted into knowledge, and knowledge can actually save lives during a pandemic. So right now, what's obvious to us, especially in Montreal, where Montreal North has been the epicenter of COVID-19 in Canada and one of the top 10 worst places in the world, is not that COVID sees color, COVID sees poverty. And poverty in Canada is very often Black or brown. So when you have a premier that doesn't recognize systemic racism, it makes it very hard and challenging to combat this kind of entire mindset. And we talked to a lot of people that say, hey, Thierry, but are you insinuating once again that it sees Black people more than it sees white people? And once again, that's not what we're saying. We're just saying that this pandemic, to us, as far as we're concerned, and what the data shows, is that it's a socioeconomic pandemic that is somewhat masquerading as a health pandemic. Not that the deaths aren't real, the deaths are real. But in reality, it's Canada's refusal to admit that the most vulnerable people in this country have been BIPOC people. So I've done a lot of panel on this, discussed this conversation and this topic a lot. Doctors have to be involved, right? It's a pandemic, but I would urge our governments and anybody on this call also to understand that having economists on these panel and sociologists, because mental health so far in the data that we've collected, especially in the 18 to 30-year-old Black youth, are literally 22% more likely to have their mental health impacted and 5 times more likely than white youth. So I think we need to truly understand that post COVID-19, we might be looking at a mental health pandemic, or at least an epidemic. So I think it's something that's very important to consider. And at Colors of COVID, it's been at the forefront of what we care about.
100%. And I mean, the Quebec numbers speak for themselves. I think they have almost half the deaths in Canada. So
that's exactly it. That's exactly it, Dwight.
One of the questions we have here, Dr. Bird, is people want to know who developed these vaccines. We hear the names Moderna, Johnson & Johnson, and AstraZeneca. People are asking who developed these vaccines.
I know that a lot of people are hesitant about vaccines because they say big pharma, they've got, their reasons why they want to develop these vaccines. They're making lots of money from the vaccines.
My WhatsApp is filled with Bill Gates' name.
Yes, exactly. So this is part of the misinformation that's out there in social media. And I think contrary to popular thinking, many of the vaccines that we're using now for COVID weren't developed by the so-called big pharma companies. 3 out of the 4 vaccines that have been authorized in Canada were developed by scientists in universities, research institutes, and relatively small and up to now, fairly new biotech companies. For example, the vaccine that we say is Pfizer was really developed by BioNTech, a smaller company out of Germany. It only started in 2008, and they were developing their mRNA for cancer treatment, and they realized that they could also use it as a vaccine. So they asked Pfizer to collaborate with them because Pfizer had a way to deliver the mRNAs without it breaking down. But more importantly, Pfizer had this great manufacturing capability, and they were able to produce large amounts of the vaccine, and they have their distribution networks going already. The other mRNA vaccine, Moderna is a small biotech company in the US, and their vaccine was actually developed from the US National Institutes of Health, Barney Graham's lab, and the main researcher there was a Black woman scientist called Kizzy Corbett. She developed most of the background work around the S protein to get it into a form that could be used as a vaccine. And so she and her team collaborated with Moderna, who also had that delivery vehicle. And this is what we're seeing. We're seeing that the main role of big pharma is to get the manufacturing processes at a large scale and to use their network of delivery to get the vaccine out. But many of the, most of the science was done in smaller companies, and many of the scientists who were involved were Black scientists as well. So it's a bit of a misnomer saying that big pharma is responsible for these vaccines. So I'd like to get that message out there because, you know, big pharma has a certain connotation associated with it.
Like deep state, yes. Right?
Yes, exactly, yeah.
And that was one of the questions if any Black doctors were involved in developing the vaccine. So thank you for answering that ahead of time. I had read that Donald Trump did the BioNTech Pfizer vaccine. I heard he did that one himself. I'm pretty sure that's what I read somewhere, but I am joking, of course. Dr. Tex Kissoon, a question for you. Can the COVID-19 vaccines be used in children? And this is one we're hearing a lot from people.
Yeah, there is no compelling reason why the vaccine cannot be used in children. In fact, when we look at the children vaccine sort of schedules, they immunize on a regular basis with vaccines that use most of the same technology as the AstraZeneca has been described. There's now some more studies that are being done that included children, but the fact is that the inclusion of children were a little late in the undertaking, mainly because of the fact that this is one of the first, surprisingly, one of the first respiratory pandemic or respiratory infection that disproportionately affected adults more than children. So the number of children we prepared in ICUs and hospitals to say there'll be thousands and thousands will be overwhelmed with children because of smaller lung capacity, etc. This has not borne out to be the case. But yes, I would say in general, for the children who are vulnerable to respiratory infections, etc., who have certain immune sort of dysfunctions, they should consult with their pediatrician, because I think that the risk of the disease in those high-risk groups outweigh, the benefits outweigh the risk in these children getting the vaccine. So yes, I would say go ahead.
I carry an EpiPen and I am allergic to crustaceans. Are the vaccines safe for people with severe allergies?
This is a great question because I know people have been worried because of the reports of anaphylaxis to the vaccines. I know specifically people are mostly worried about the mRNA ones. I want to first point out that the risk of anaphylaxis from those vaccines is about 2 per 5 million doses, so very rare. And if you have a known, let's say a food allergy like yourself, crustacean allergy, or perhaps you're allergic to peanut or milk or wheat, those are not contraindications to this vaccine. The main concern is if you are known to have perhaps anaphylaxis to a first dose of the vaccine, that's a contraindication, or if you're allergic to the components of the vaccine. Now, I'm going to go into what's in the vaccines, but before I do, I want to tell you what's not in the vaccine. There are no foods in the vaccines. So there's none of the crustaceans, shellfish, milk, wheat, egg, none of those are in the vaccine. So if you have any of those food allergies, that is not a contraindication. There's no kind of common allergens like grass or pets, dander. There's no venoms, which come from things like bees and wasps. So all those, which can also cause anaphylaxis, those are not in the vaccine. There are no dyes in the vaccine. And there's no thimerosal or mercury, and there's no formaldehyde in these vaccines. These vaccines are actually quite, it took a long time in terms of getting the technology for a while because we were trying to stabilize it because they're very sensitive. So there's actually not too much in them. There's a bit of salts, which our body's normal and used to having. And then there's a bit of this lipid layer, which is kind of the oil layer to kind of keep it intact. So there's some kind of cholesterol, which we have naturally in our body. It's not a animal-based cholesterol, so there's no concerns from like a cultural perspective either. And then there's some components that's called polyethylene glycol, which is essentially a type of lipid to help stabilize it. It's extremely rare to have an allergy to this. And if you do have an allergy to this, you often are followed by an allergist because it is in so many medications that you would have been previously identified, and you cannot essentially buy many over-the-counter medications, okay? And then the other component that's slightly related is the polysorbate, which is in the AstraZeneca and Johnson & Johnson ones. But allergies to those, even though they are described, are extremely rare. These few patients who have those are often followed by a specific drug allergy clinic. And I can tell you that even as myself, I didn't have one patient with these, but they're extremely rare. Those are the only people who have to be worried from an allergy standpoint. But other allergies for which you carry an EpiPen, foods, venoms, or if you have single antibiotic allergies, if you have penicillin allergy or sulfa allergies, those antibiotics are not in this medication. There's no antibiotics inside the vaccines either. So from that standpoint, I hope that helps alleviate a lot of people's worries from that standpoint.
How long will the vaccines protect me, and do I need a yearly shot like we do with the flu?
So this is going to be something that we're hopefully going to be able to answer over time. Because that has so many factors that play into it. So, we have seen that with some vaccines, if you fully eradicate the disease, sometimes you don't need boosters. A good example of this would be smallpox. They actually really eradicated that, and now people don't get vaccinated for smallpox anymore because we don't have a reservoir. But sometimes with viral infections, we still kind of have some in the reservoir, so there might be something that we may need to get boosted to. It's going to really depend on what happens over time and how well our immunity carries. So for example, with influenza, we do have to get a yearly booster to help us kind of stay protected because it kind of wanes. So it might be that this will end up being something like that. But at this point, we're still learning, and we're still following people who have been initially vaccinated and seeing over time. So, and this is not unusual. I don't want anyone to walk away saying, do we not know what to do? This is not uncommon at all. For example, we vaccinate for mumps, measles, rubella. And for a long time, we used to only give one vaccine. Then we noticed, wait a second, all of a sudden we were having people who are at the end of high school, beginning of university, who were getting measles again or mumps. And we thought, maybe they need a booster. And then we changed our system. And now you get 2 doses to protect you from mumps, measles, rubella, because we noted that it was not giving you that long lasting protection that we initially thought it would. So it's not unusual to go back and look at how we have done our vaccine schedule and modernize it. Similarly, in young kids, we actually reduced one of the vaccines because we realized they probably don't need that extra dose. They actually get a great response. So it's not unusual that we kind of alter that based on how much of the disease is in the community and how, if it stays endemic or if it goes away. So that will change over time, and it's really going to depend what happens.
Can the vaccine affect the likelihood that a woman will get pregnant?
So the short answer, no. These vaccines do not interfere with a woman's ability to be fertile or to be fertilized. They do not interfere with the man's ability to be fertile and to fertilize. So that's a short answer. Dwight, just let me digress for a moment because there was a question about pregnancy in the chat. Mm-hmm. So the Pfizer's come out and they're doing trials with women from 24 to 34 weeks. And the question is, can women who are in the earlier stages of pregnancy have the vaccine? And the short answer is yes, as we said before, particularly if that woman is in a situation of higher risk for acquiring COVID infection. There are a lot of scenarios that we can talk about if we had time. Essentially, if you've had the vaccine and you become pregnant, then not to worry. There is a question as to whether you should delay the second dose because of maybe a febrile response in the first trimester. But as we know now, the second dose is going to be delayed by 4 months anyway. So I just want to reassure everyone that these vaccines are recommended if you're eligible, if you're pregnant or breastfeeding, and the trials are being done to kind of confirm the safety.
A lot of people ask, can mRNA vaccines affect my DNA?
There is no way the mRNA can affect the DNA because it doesn't get into the nucleus. The mRNA stay in the cytoplasm of the cells. It is the mRNA vaccine is just a vehicle giving the information to the ribosome of the cells in the cytoplasm to produce the piece of viral protein. So it doesn't get into your nucleus, doesn't interact with your chromosome, doesn't interact with your gene.
We keep hearing about these variants of concern over and over, the UK variant, South Africa variant. Can you comment on what is known about how effective the vaccines will be against the new variants at this point?
So far, the vaccine that we have a high level of protection against at least the UK variants. You know that AstraZeneca has been used a lot in the UK, and the two vaccine, the AstraZeneca and Johnson & Johnson, were also studied during the phase 3 trials in some of the other countries where we have a variant. So you have a South African variant and you have a Brazilian variant. The level of protection was has dropped for AstraZeneca, but it was slightly higher for Johnson & Johnson with regard to the South African variants. But they didn't study the Brazilian variant. It was not studied against AstraZeneca. The Johnson & Johnson has relatively good response against the Brazilian variant because the study that was done in Brazil, they had around 68% efficacy. And in the US, it was 72. So we could say, we could at least, here in Canada, we have most of the variants which has been detected are the UK variant, and the vaccine that we have all protect us against that UK variant. You may have some mild drop against the South African variant, but you can still have a relatively high level of protection as compared if anyone didn't have any vaccine. Can you buy the vaccine to get vaccinated sooner?
That is a question that I'm 100% not competent in answering.
Right? I was reading it, I'm like, why would I put that question?
I believe in, talking about things I know, and if I don't know, I believe about educating myself about it.
I'm gonna say no. I'm gonna say we're not allowed to buy. We've got a great healthcare system in this country that takes care of us like that, but no, I would not go out there and try to buy vaccines because I would be worried about their authenticity on the street. This one says, are the vaccines mandatory? What if I refuse to be vaccinated? And I'm pretty sure they're not mandatory in Canada at this point. Can I get a head nod from my panelists for that? Or if anybody wants to jump in there.
They're not mandatory. So if you refuse, if you're offered vaccine and you refuse, nobody's going to put you in jail, et cetera, et cetera. So yeah, short answer, they're not mandatory.
I took the vaccine because I'm a PSW in the community, and I go into various homes, and these homes I go in to have their family, and these people are in contact with their family every day. So I am exposed to the virus when I go into these homes. But most of all, I took the vaccine because last year we were really hardly hit. My husband lost his son from the virus. My sister-in-law died from the virus. My two nephews died from the virus in the States, and lots of close friends and family. So we
got hard hit last year. Last year, we lost so many family members. So this virus is not a joke.
I've known Dr. Tam for many years. When I was at the University of Ottawa, she's a physician with expertise in immunization, infectious diseases, emergency preparedness, and global health security. So it gives me great pleasure in introducing Dr. Tam to us today. Teresa?
Thank you so much, Upton. It's amazing to be here, and thank you for this amazing and gracious invitation. I was just logged in a few minutes ahead of time, and I could see that was an incredibly rich discussion, and people were really engaged and participating. So that's really great. And yes, I've known Upton for many years, and I was a pediatrician, so we sort of grew up in this sort of similar community of practice, if you like. So I am from Ottawa. I'm on the speaking with you today on the traditional unceded territory of the Algonquin Anishinaabe people. And I've been the Chief Public Health Officer now for almost 4 years. And when I started, my goal was actually about health equity. I really wanted to do whatever I could to ensure that all Canadians have the opportunity to reach their optimal health. So, because everyone deserves this. And so I have to say that moving from clinical medicine to public health was quite a transition. My mother goes, "What on earth do you do? Why aren't you, looking after kids and babies?" And now I think she pretty much knows what public health does, and maybe a little bit about what I do. But in my annual report of a couple of years ago, I highlighted the topic of stigma and discrimination in the healthcare system and the inequities experienced by many different populations, including Black Canadians, something that I'm sure you all know too well, and that this kind of inequality in Canada is not new. And certainly in COVID-19, we're seeing how this virus, this illness, is hitting some Canadians much more than others, and that the rates of illness are higher in racialized neighborhoods, and so and low-income families, because people have to work outside their home. Some of us can do virtual medicine, or we can stay at home and do our jobs, but many can't. They're on the front lines. I've heard that people on the last conversation saying, we now recognize how important the people who keep our food coming to us, or people who drive trucks across the country, or are so important, people who look after our elders, our seniors in long-term care homes, who themselves may not be in a safe condition, and they don't have the necessary pay, sick leave, or other conditions that help them look after themselves and their own families. And so obviously there's been a bit more data coming out to demonstrate just how hard it's been hitting some of these populations. And, I think in Toronto, if you're from Toronto, of course, there's actually statistics to show how Black Torontonians are consistently overrepresented in cases and hospitalizations. And so really, I think Canadians could see how health, social, economic well-being are interlinked, and this is now in full display. So I think, but I also know, and I've just heard some individuals in this meeting say, we have come together. Communities have come together and supported each other through these difficult times. People are volunteering in the community to look after each other, which is really the only way that we can help protect everybody, and certainly not just for this pandemic, but in other pandemics to come. And there is definitely, I think, a stronger societal understanding and the need to address the barriers for health equity. And so certainly I applaud so many of you for your work, not as health professionals, but also as community members, from whatever job you're in or where you come from, that you have helped, I think, make sure that the efforts of this past year are remembered, and that we don't forget these disproportionate impacts that we have seen. I have been connecting with my colleagues in Nova Scotia, for example, and I was learning about a collaboration between the Health Association of African Canadians and the Association of Black Social Workers in Nova Scotia. And they've organized a COVID response teams and regularly hosted town halls, a bit like what you're doing today, for community meetings that engage the Deputy Chief Public Health Officer, who might really of African descent, and other health professionals. That's really important. Looking forward, many of you talked about vaccines, some of the take-home messages. And so this is a key next step for public health and for our country and our communities, is the vaccination campaign. And so, it is important to address questions that people have, and questions that may come from your communities. So I'm really happy to see Dr. Allen and many others trying to address this today, and nurses and pharmacists and others can help. And so any, the many reasons for people not wanting to take the vaccine can be quite complex. And so some of it is just about trust. It's about trust in the medical system and in the people working in it. So that we know is in the background of why some people might be hesitant to take the vaccine, and others simply don't have access. So I'm really happy to see that in some communities there are mobile vaccine clinics, for example, because people can't get to some of these vaccine sites. And so some of it is fundamental about access to all. And so that's really, really important. And getting the right information. I was so happy someone mentioned the Public Health Agency of Canada website or the websites of your local public health units, because that's where you can get some of the information that you can be confident in. All medications and vaccines have some side effects. You should know about them. You should expect them. But the vaccines that we have authorized in Canada are safe and effective. They've undergone the studies and trials in many places across the world. So I think boosting the trust in the vaccine program will get us out of the crisis, what I call the crisis phase of this pandemic, as fast as possible. Without a vaccine, it would be really very, very difficult to do. Trying to keep up with reducing transmission, and it is so difficult. People can't do distance from one another. We're social animals. We have to connect with our families and others. So the vaccine really will help us in that. So I think really count on the trusted voices in your community. If you've had a vaccine, talk to people. If you're on social media, put this on your social media, tell people, have conversation with your families, and point them to the right sources of information. That's some of the concrete things that you can do. And so also, just to put a plug in one of the programs we've launched called the Vaccine Community Innovation Challenge. This provides funding to help people promote vaccine confidence within your communities, and we can send you more information about that. But even with a vaccine, one of the key messages is still stay vigilant, maintain these public health practices, your personal protection practices for now, because the vaccine rollout will take some time. And so I am leaving you, maybe, I hope, feeling hopeful about where we're going and your individual roles in ending it. And I would just say that a quick quote from Cheryl Prescott, who's leading the COVID-19 pandemic response with the Black Creek Community Health Center in Toronto. And her words sum up my hope for the future and returning to a better tomorrow, one that we don't forget what just happened and bring it forward. And she said, we cannot simply go back to the old ways. Instead, we must fix what has long been broken. We must reimagine a new normal that makes better health accessible for all. So I wish you every success in everything that you're doing now. So thank you very much. And thank you, Upton. It's great to see you.
Thank you. Good to see you too, Theresa. Have a great day. And thank you so much for being with us today, and wonderful words. And we really appreciate your time.
I just want to thank all of you for taking the time, 3 hours of your time on a Saturday, to be part of this event. I think it's important for us to send this message. We've heard about your concerns. We understand that this town hall is just really part of a bigger conversation about the health and welfare of Black Canadians and racialized groups in Canada. Both the Black Opportunity Fund and BlackNorth Initiative want to walk with you on the journey with each and every one of you. I think it's important for everyone to understand that no one that participated in this event today was paid. We really care about each and every one of you. We want to continue this discussion on social media. So we want you to visit our websites, both Black Opportunity Fund and BNI, BlackNorth Initiative, to continue discussion on Twitter, LinkedIn, Facebook, Instagram, and email us.
I just want to thank all of the doctors who took the time, and the community members and the nurses and everybody who care about our community so much to take the time this afternoon out of your Saturday and come here and try to provide the information that is so needed within our community. And I really want to thank Dr. Allen and Dr. Sechioto for asking me and allowing me to be part of this incredible conversation. Thank you so much.